Welcome to this episode of Athletic Training Chat. In this episode, we are on with Jonathan Reidy. In this episode, we really focus on the physician extender role of athletic trainers and the different roles that athletic trainers can have when it comes to the clinical setting and the different options there, looking at not only that, but outreach and really the skill sets that athletic trainers bring when it comes to this setting. It is one that is probably moved out of the emerging part of everything and moved into one of the new stable areas of athletic training, and one that will continue to grow as athletic trainers keep demonstrating their usefulness and their ability to thrive in this setting. As always, we are powered by Mueller Sports Medicine. It's about that time of year to start getting bids ready and figuring out supplies. Give them a look from everything from tape to braces, well worth checking out. And as always, contact them if you have any ideas or questions. They'd be happy to hear from you. With that, enjoy this episode. Welcome to this episode of Athletic Training Chat. We are on with Jonathan Reidy. Hopefully I said that correctly. We are talking athletic trainers in physician practice and how that works. This is, again, relatively timely. It'll probably be a little while out, but there was a little brush up as we were just talking off camera about what that actually looks like and advocating for the profession and so on and so forth. But we'll save that for just a little bit. Before we get into that, please fill us in on your background and how you are where you are today.
Yeah, so I think my story is pretty typical for a lot of us that had an injury playing freshman sports in high school and basically never left the athletic training room after that. Started with a couple of successive injuries and then was like spending so much time in there anyway. It was like, oh, what are you doing? And started poking around with my athletic trainer. And I was fortunate he kind of tolerated me enough to let me hang around, and it was kind of rolled right from there. Went to Springfield College in Massachusetts. Had a great experience there. Had some awesome opportunities. I think we'll get into in a little bit. And after I graduated, my now wife and I moved to North Carolina. Just kind of getting out and doing something different. I grew up 15 minutes from where I went to college, so I never really left or did anything else. So. We started a private middle school down there, did that for a few months, and then that was part-time. So I actually had a high school job open up, and then moved over to that high school. And part of that was we got kind of absorbed by Wake Forest Baptist Health, which is a big hospital in the area, tied to Wake Forest University in their medical school. So I was there for about 3 years, and I think it was like February of 2019, we decided we were going to move home back to New England. And my wife had just started nursing school. It was an accelerated program. So I was like, all right, we'll work this. I'll work this last year at my school. And then once we're done, we'll move back up this way. And early summer, one of my professors from Springfield, his wife actually works at Shriners. And he was like, hey, this job's not posted yet. It's coming up. You should apply for it. And I'd actually looked at another job, didn't get that. And so I told my principal and my AD, like, hey, I'm just looking at this one job. That's it. If I don't get that, I'm not leaving yet. And then they posted the Shriners job. And I was like, I really don't want to go back on my word. But so I didn't apply. And then like 2 days later after they posted it, our AD announced that he took a new job. So I was like, here's your sign, that's a big question mark. So kind of applied, went through the process and got it, and then had a quick 3-week turnaround to empty out our house and move back to Massachusetts. And so we actually did long distance for a little while here.
Okay.
While she finished school. She just finished a couple weeks ago. So, but yeah, the Shriners job's been great. It's kind of a hybrid role, a little bit of physician practice, managing our outreach program, kind of doing a lot of the strategic planning stuff with our sports health and medicine program as a whole. That's kind of a new program for us.
Awesome. Just to kind of get the whole process started with the questions. From my experience, which is minimal in the athletic training in the physician setting, seen it a couple places, kind of evolving currently where we're at in our partnership with the health system here. But what is the setup in your guys' clinic like with athletic trainers and how they're used and just kind of the background of that?
Yeah, so I'll get kind of the whole overview of our sports health and medicine program at Shriners. So we started in 2017. We had one athletic trainer, and then we had a we had a physical medicine rehabilitation specialist. So he came in as a consulting physician, and he did every other Friday afternoon. The other athletic trainer, she kind of started doing some of the community outreach stuff, a lot of like community benefit things. They then brought on another athletic trainer for a charter school in our area. So she's full-time out there. And then right like a week and a half before I started or got hired, they'd actually hired another athletic trainer. She works out at a private athletic facility. So it's like a private, they've got 3 outdoor fields, 3 indoor turf fields. They do a whole mix of stuff. And then I replaced that original athletic trainer, kind of overseeing the outreach program. So I started there in August, and then in October, we had a new orthopedic surgeon start. So he was actually trained, he actually did 2 fellowships. He did a pediatric orthopedics fellowship at Columbia, and then also did a sports medicine fellowship at Cleveland Clinic. So he kind of had that dual experience, which has been really cool to kind of learn from. So part of what he wanted, part of his training, he had an athletic trainer that they worked with. So that was kind of one of his requests right from the get-go, to have an athletic trainer presence in clinic. So I think initially we kind of, truthfully, we're both kind of, obviously feeling each other out. There's that kind of, that new period of, we're new to each other.
Right.
How does he like to practice? What am I used to? So I think we had that kind of feeling each other out period. But he also, at the same time, was kind of hitting the ground running, and he's doing ACLs, and a lot of these procedures weren't being done at our hospital because they didn't have a sports surgeon. So, so initially we started doing a lot of exams. I'm in there Monday and Friday with him. Mondays is kind of more pediatric orthopedics. Fridays predominantly sports, but we see both on both days. So we're seeing probably, I'd say, a little bit more heavy on the sports side. There just wasn't a lot. There's a big surgical group in the area. There wasn't a lot of other options, especially in the pediatrics, that we're seeing some of those. It's unfortunate. Obviously, we all see the trend in the younger ACL players, but he does a couple of, just a little bit more cognizant about the growth plates and how we're working around those, or if we have to engage that growth plate, how are we doing that? And
yep.
So we're doing a lot. We've kind of found our groove the last few months here, doing a lot of like home exercise teaching, to kind of getting our kids, going on some exercises before they get to PT. At least in our area, it's almost a 2-week wait for almost anybody to get in for PT. So we're doing a lot of that, kind of get them jump started. And, we're working really closely with some of our community athletic trainers that aren't necessarily Shriners employees, but, we've gone out, him and I have gone out on some of his admin days and actually gone to high schools and sat with their athletic trainers and said, this is what we have to offer, what things, how can we engage with you guys, and, what's the best way for us to share patients. And so we're doing a lot of sending kids back to their athletic trainers for, you get that acute ankle sprain that comes in, they've already been to urgent care, they come in and see us, we make sure there's nothing further. Then we work on that return to play with their athletic trainer. So we're trying to engage a lot of the local athletic trainers. He does a great job. He communicates after visits. So that's like part of our clinic operation is, do you have an athletic trainer at your school? Do you work with them a lot? And, kind of feeling that out. Mm-hmm. So trying to kind of keep them in the loop, which again was something that was important for him. That was part of his practice. That he said, this is something I want to integrate right away. So this becomes kind of one of those foundational pieces.
That's awesome and very helpful, especially when the orthopedic surgeons are like,
right,
what we want. Yep.
Right.
Kind of aside to that, you talk about the home exercise, right after their appointment before they get to PT. That is something that has been implemented with the physician we work with and the ATs that are there. They're not billing for that. They're not going through and doing it, but I don't in terms of like time use, it's not significant from the athletic training side.
Right.
But I think the patient satisfaction has been awesome. I know just in me doing some observations, some shadowing, some of the responses have been really positive. What have you seen as, with patient happiness with some of those things?
Yeah, I mean, I think it's a good opportunity. I think we're used to being in that setting where, a lot of our kids are getting the news that, yeah, hey, you tore your ACL, or you got a meniscus tear, or you have something that may require surgery, or you may not, So I think especially for our surgical kids, I think it's an opportunity, one, to give them something that they can control, right? They've just had an injury that more or less is out of their control. They really can't help it. So, we're giving them a task that they can control. They can choose to do this or not. For me, it's a good opportunity to engage with them, and you can kind of have. I feel like we as athletic trainers tend to get a little bit more like of a personal relationship with the athletes and patients, and you build through these exercises. One of my go-tos is okay, we finished going through it, and okay, I know you're out of school today right now, but there's a test, and that usually gets a good chuckle from the kids and the parents, and so I feel like that having that kind of a more interaction in that environment gives them a chance to kind of relax and kind of process some of that news, and almost always they usually have a couple of questions, not just about their exercises, but what is the process? Am I going to be able to play sports again? We had a kid yesterday that, he's a senior in high school and is interested in playing college sports. So they're like, hey, how do we have that conversation with coach? Or what does this transition to care look like? If, right now, obviously with everything going on, it's a little funky, but, being able to offer like, hey, let's have that upfront conversation with your coach. You've already connected. Let's keep him in the loop. Show coach, hey, I'm taking these steps to be engaged and doing what I need to do. Being able to talk about like, okay, here's how we can transition care to your athletic trainer once you're under their care as a college athlete. So being able to answer some of those informal questions, I think is helpful. That it's just a little bit less formal time. So I would think we do patient satisfaction surveys, but I think there's a delay in when they come in.
Right.
But because we're still pretty new at this, I don't know that we're far enough down the line to necessarily see those numbers change yet. But
sure.
But I would imagine, I think especially now where we can give kids, hey, we know it's going to be a little bit before you get into PT, maybe even longer than normal with all the Corona stuff, that, here's something you can do to work on getting better. Like you can actively do this every day. You can work and be able to do something about it instead of just sit and wait for, either waiting for it to get into PT or waiting for getting, your wait list call to get surgery scheduled. That, I think it gives them something they can work on.
So we were talking, like I mentioned earlier, about a little dust up that happened when somebody kind of posed a question, what the athletic trainer's role is in a hospital or clinic setting. Obviously, I think it can vary, like private practice, orthopedic group versus more hospital.
Right.
Because I know for us, it's a very traditional hospital, with nurses and CMAs, and it's been a very successful hospital. So I don't question them on it. It's just I would make it more traditional. But there was some opinions about where the AT falls in that, what that looks like, what it should look like. What are your thoughts? Is it you mentioned that there are CMAs that you work with, but what do you see their role versus the athletic trainer's role? Like, are you going in and doing the initial evaluation as your physician's kind of running around trying to keep up, because you guys are at that level of busyness, which is a good and bad thing, I guess, technically.
Right.
Just what do you see with that? Like, how does that work? I mean, there's so many other things that can kind of get other people that can get thrown into that care team. Right. Thoughts?
So I think part of it comes to your mindset. I think in the last 4 or 5 years, I think we've seen this push to be, we're all part of the sports medicine team. I think that's becoming more accepted. People are realizing, like, listen, can't be a standalone office with one provider and do sports medicine. Like, there's got to be other pieces to that team. And I think some of us is just being more open-minded about who's a part of that team. We've all got a role to play. and, I think it's being cognizant of what other people's roles are. And, yeah, sometimes there's some overlap. But I think it's remember to step back, don't take things personally. Like, I'm very fortunate. Our physician is phenomenal. He understands our skill set, what we can do to help him, what we can do to help the patient. And our CMA is great. Like I said, he wanted an athletic trainer as part of his clinic from the get-go. So it wasn't something new for his practice that we had to add in later. Like, there wasn't really an established, there wasn't roles established. There wasn't a hierarchy. This was all new for everybody. So we work with the same CMA every Monday, Friday, with obviously the exception of, if she's sick or, right now, like, yeah, she's got a 6 or 7 year old and he's home from school. So, obviously we make adjustments and everybody's adjusting now, but, we conference the three of us before every clinic. She'll typically room the first patient and then we come back, we look through the whole day. All three of us look at it from a different lens. So, we all kind of review ahead of time and, we go through each patient, what are they coming for? Do they have x-ray or do they need x-rays? Are there orders in? Do they have an athletic trainer at school obviously we don't know until they get there, but if they're from a certain town and we know that high school's got an athletic trainer, like we kind of keep those things, we each kind of keep tabs on certain pieces of those patients and then kind of put it all together beforehand. And, I think it's been great. We really haven't had, at least to my knowledge, we haven't had any issues with, stepping on each other's toes, but it's a lot of open communication. We're constantly talking like, hey, this is a task we need done. Who's going to do that? I'm available to handle it. Do you want to handle it? So it's a lot of constant communication back and forth. And like I said, I think where there wasn't any preconceived ideas, there wasn't any, I think this is my job. It's been a lot of just open chain communication and making sure we're always talking about stuff before. Obviously we always try to talk about things before they become a problem. And, if there is, it's our hospital's great. We've kind of got this, there's this culture that it's not about blaming people. It's how do we do things better for the patient? So, and we're fortunate to kind of have that culture. So, in our setup, I think we're very lucky. We don't have those issues that kind of came up in that little thread there. But,
right.
I think if you've got people who are in a pre-established setup coming and trying to change that, I think that's where you get some of those frustrations that people feel like they don't know where they fall in, but sometimes people aren't willing to have those conversations. So, like I said, we've got a physician who's driving a lot of that, so that helps.
Yeah, the personality is huge, especially with a physician that's getting it and understanding it, which is not always the case, but
right.
It always make things interesting.
Yeah.
Man, I had the question about what, physician satisfaction with having an AT, but with your physician already coming in and asking that, I don't know if you've looked at any of the different research stuff that's been out there just within physician ATs and physician practice, and any thoughts of continuing to push more on getting people like yourselves or anybody in this role?
Yeah, I mean, I think this is such a new area. You look at the grand scheme of things, it's such a new area for athletic training that, I think a lot of physicians are starting to see the benefit, and you start to look at efficiency. We're fortunate we don't have as heavy of a focus on efficiency. Our the way our system runs, it allows us to kind of focus on the patient without real concern for our tagline is care regardless of the ability to pay. That's just part of the Shriners system. So we don't have to try to crank out 60 patients a day to be able to make sure we can meet all the bills. So I think that allows us a unique opportunity to, it's okay for it's easier for us to be there. We don't have to worry about as much of the billing things as some other places do. But I think you look at the places that do have to bill. I think one of the things we've talked about is the home exercise program teaching for us, it takes me 10, maybe 15 minutes if we're both kind of chatty, but that's, if we send them right upstairs to go to PT, they have to do a whole eval just to be able to give them a home exercise program. So from that sense, like that there's value there that, or adjusting their crutches, same thing. They have to do, PT is going to have to do a full eval to be able to adjust their crutches and give them a home exercise program where, again, I spend 10, 15 minutes with them. and they get what they need. PT is able to keep that open slot, especially, for a patient that needs it. And, we've had a huge uptick in rehab needs with a sports surgeon coming in. So, we've definitely kept PT busy, and they were busy to start with. So, it's nice to keep those slots free when we do have, we're having a lot of kids who need those slots. So, I think that's been good for rehab. I think they're appreciative that they don't necessarily have to give up that whole slot for what's really 10 or 15 minutes worth of work. I think in scenarios where they are billing, I think, again, certain states are doing it, obviously, and obviously there's a lot of conversation around that and more resources available and so on. But, we're not doing the billing right now. So I think for us, it's not as much of a metric right now. But, I think it's great for our doctor to be able, it's things that he wants done. If a couple of times we've had clinics that get really busy and, he can move on to the next patient, and, they're not feeling like they've been dumped off and just, I'm in there the whole visit. So it's not like, oh, now there's a new person coming in and they're just getting passed person to person. I think it comes across as like, hey, our whole team is interacting with you today. And, you're getting different pieces from our whole team. So I think the physician definitely has been happy with it. And, I think others will start to see like it's just different skill sets, and having different skill sets in the room obviously provides different opportunity to do different things. So
do you think with the billing, especially in your case, in the place we work with, their motto, their tagline is the needs of the patient come first. Kind of similar, but I really like the Shriner one. Because we've looked at it like the argument of third-party billing just in terms of justifying more people, or does the throughput and what you're able to get in terms of, not over-prescribing, but looking at diagnostic ultrasounds, MRIs,
right.
injection, whether they're diagnostic or therapeutic for different things. Do you see potentially, from what you've kind of gathered, a need to eventually look at billing for some of those smaller things, or is the throughput and the overall general satisfaction? Because if you have a happy orthopedic surgeon, usually that's a good thing for a hospital system.
Right.
Do you see the need for it in the future, or do you think as of now it can be done without it and ultimately potentially benefit the patient?
I think for us it's I think we're in a unique situation. Athletic trainers are new to our whole hospital system. Right now there's only 5 of the 22 sites we have. 4 of them are in Springfield. So we've got 22 locations throughout the U.S., Mexico, Canada. There is another athletic trainer in Florida, but she's in a little different role. So, this is really, really new for Shriners. So some of it's like our EMR. So we're working through some things with that, with like our IS team, and, how do we document? What are we documenting? So those are some of the challenges we're working through. And, obviously we've got a great team that's working on it. Obviously all the coronavirus stuff kind of pushes some of that to the back seat a little bit, which obviously makes sense. Like this is obviously the priority that needs to be managed. And, and then once we get through this, then we'll come back and keep working on those tasks. And, and it's great. I think I feel very fortunate. We've got a lot of people at the hospital. We're not necessarily aware of what athletic trainers were and what we do and kind of how we fit into that team, but I think they've been really open to learning. And, I've been fortunate. I've kind of got my set PowerPoint now of, what is an athletic trainer? What's our education? What's our background? What settings do we work in? And I think I've done that maybe 3 or 4 times now. But people are willing to learn and willing to work with us. And, that's such a crucial piece that, it's a uphill battle as it is to try to kind of justify who we are and what we do. And, having people that are willing to hear that message and to learn about it obviously makes a huge difference. So I feel very fortunate to work with this organization and be able to have the opportunity to kind of share that stuff with them. And again, having a surgeon who that was just kind of his expectation. He already knew that stuff. And obviously that really helps to have the physician drive that too. When you're not having a win over on top of it. So, and I think everybody, every day they feel, oh, I didn't know you could do that, so it's this constant learning and educating. And, I really like that about my role. I like that I have the opportunity to share athletic training with other people. And, hey, this is how we can help you better care for your patients. Like we can all do this together. But back to the billing, I think eventually, if we work through some of those things, I think it's like the rest of the, in any other area, we bill where we can, and if it doesn't happen, it doesn't happen. But I think if there's an opportunity there, then certainly we would look at that. But obviously, we want to be in the right place to do that first.
Absolutely. Anything else around the physician extender role that you want to cover that we didn't get to?
I think it's it's a little bit. I came through a traditional setting, so I think it's definitely a little bit different. I think there's definitely miss having like my teams and my athletes, and you connect on a different level in the traditional setting, I think. But I think now that we're doing some of the teaching, and we're there from kind of start to finish. I sit in the rehab department, so I'm walking through all the time. So I see kids. We saw them on their initial eval. Went through. Some of them I'll hop in and watch surgery sometimes. We've not really explored that facet yet about helping, but so we're only I get going and I'm like, oh, let's do this, let's do that, and so remember to step back and okay, we've only been doing this since October. We're only 4 or 5 months into this, so I'm sure this will continue to evolve. But I think that's the other thing too, is being open to what else can you do. I think we've got a great skill set that is adaptable, but I think we need to be willing to do that. Like I'm not using all the same skills that I used in high school,
Right.
which again, there's pros and cons to anything, but I've learned so much in the last, I don't know, since October. I'd seen, we've all seen an MRI before, but
absolutely.
To kind of scrutinize that a little bit. Pretty good with knees now. I can definitely tell you if you got an ACL tear or not. Work getting there on meniscus.
That's honestly my biggest jealous point of people in the clinic is the radiology aspect of it, because it just baffles me, and that I've never spent time with it, and would love to get better at it. Our physician's huge on diagnostic ultrasound. One of our ATs there is like, I can pretty much, because he's seen so many of them, pick out a lot of things. I'm just like, dude, I'm still trying to figure out where everything is on the screen.
Right. How do I orient this?
I'm still trying to figure out how to orient myself.
Right. But I think it's, and our physician, like I said, he's awesome about teaching. So, he does a lot of the all right, you look at it, tell me what you think, and then we'll go through it. Don't look at the radiology report first. Go through, look at it. So he's really kind of made a learning experience for me too. And,
awesome.
Definitely feel like I can talk a little bit more in depth about it, about, what is the procedure? What's, more of the anatomy that obviously we cover that, but having some more, once you're out, you don't always get a lot of the refresher on it. So kind of the daily, you're looking at it every day, and then you start to see, obviously there's the norms, but most people aren't the norms. So you start to look at, okay, that bone is shaped differently than most of the ones I look at. Okay, is that a problem? Is that just how theirs is? So that's been really cool. We're getting a lot of the radiology exposure, and no pun intended. But just having that educational piece, I think has been great. And being able to talk to families about it, and this is what you're looking at, and really kind of help patients understand.
If somebody wanted to get into the physician setting, I'll just leave it very open-ended. What recommendations or thoughts would you have for them?
I think I kind of fell into it, which was kind of a happy accident. It was and I've it's been awesome. So I wasn't necessarily looking to go that route, but it just kind of happened. So I think that's one thing. I mean, it's any setting you're trying to get into. I mean, don't walk by the open door if it's there. At least peek in and see what you're getting at. But if you were really focused on getting there, I think looking at having some of those additional skill sets, whether go to the course on suturing, go to the course on casting. I don't do a lot of that, but I think in a lot of practices that's going to be a valuable piece. Looking at the OTC certification to be able to help surgically, I think that's like I said, we haven't really explored that at our hospital, but I don't know if that's something down the road we look at. But I think for especially smaller private practices that that's going to be a value is, if you can be in there, be the first assist. And, I think the value comes from working with that physician constantly and knowing, being able to anticipate their needs. And, if we're doing this procedure this way, they want the knee at this angle, or, to be able to help them that way and kind of really be, as it says, physician extender, that, you're really an extension of their hands, and, they know they can trust you. And, And the other thing is the network. Like, you just never know who knows somebody. I had when I first kind of started, I actually went out. I had a classmate who was down at Emory. She went through their residency program and is now working there. And she had a professor there who since came back up this way. She's out near Boston and she's a practice manager, but works as basically a physician extender. And so I went out and spent a day with them, kind of getting connected through her. Their clinic runs a little differently than ours does. So it was great to be like, okay, I love that they do that. That's something that's not going to work at our system. But, it was great to kind of pull from other people's experiences.
Sure.
And right now it's the physician practice is such a small setting right now that there's only so many of us. So if, use your network, work your network, talk to those people, find out what they did. I'm sure some people were a lot more intentional about getting into physician practice than I was. So, but that's in any setting, work your network, like keep those contacts up. You never know who's going to know somebody. We all pass the same test. So
right.
I think that's the best way is work your network.
Awesome. Well, anything else, or ready to jump into the AT chat questions?
Yeah, let's go for it.
Awesome. First one, where do you see athletic training going in the next 5 to 10 years?
So I think some of that's setting specific. Most of my experience is secondary schools, mostly through outreach. I think if done correctly, and that's the big if, I think the outreach from a hospital is probably the future of secondary schools. I think it's a win-win for everybody. In most cases, the school's getting athletic training services at a discount. For the athletic trainer, you're really working out a medical model as opposed to reporting to somebody who may or may not understand your role.
Absolutely.
I reported to an athletic trainer when I was at Wake. So the person who was evaluating me had the same credentials, knew what I was supposed to be doing. It was really qualified to evaluate the job that I was doing. The AD I worked for was phenomenal. He was awesome. But he's not an athletic trainer. So I think for a lot of us as a profession, we've been in a situation for a long time where we've been evaluated by people who don't know what we're doing or don't know the specifics of the day to day. That they're like, oh yeah, they're doing stuff back there in the training room, but that's all they really know. That a lot of them, by nature of their job, don't have time to come and sit in the AT room at 3:00 and watch the madness that happens for that hour. And a lot of the rest of it is sitting around waiting for other things to happen, but they don't see the, I forget what we were talking about, but someone the other day used the duck analogy that, we're kind of floating out, on the surface. It looks like we're just swimming along and floating, but underneath like crazy, that
nope.
People don't really see the stuff running in the background. So I think, having that evaluator be somebody who understands that you're paddling like crazy underneath, even if it looks like everything's good on the surface, I think is really crucial for athletic trainers moving forward. Both, one, job satisfaction, looking at pay, having somebody in that position to try to advocate for you to have better pay. And, they can go to somebody who makes that decision and say, these are the things that they're doing. This is the paddling underneath that's happening.
Right.
Even though it doesn't necessarily look like it. The other thing is access to physicians. For me, I kind of fell into a great scenario when I went to North Carolina, and, I was a new grad. I was fresh out of school. I was new to that group of schools. I think there's 12 schools in our county. So I worked with all these other athletic trainers, but had never met them, didn't know them. They didn't know me. There was no network down there for me. So when Wake took over, I got assigned a physician. So there was that kind of pre-established relationship, which, for me would have been really hard to just kind of go in blind and say, hey, I'm a new athletic trainer. I'm not from here. You don't know me. You should sign off on my license,
Yeah.
So I think, for me, that was great. You have the resources of the whole hospital, be it, your surgeon, non-op care. I mean, and Fort Wake was such a big hospital. We had everything you could possibly need.
Right.
We had to do that. We had a PT clinic that was in the clinic we worked out of. So it's having those resources that, I could call my doc, like, hey, I'm not really sure about this. What do you think? I could call him or I could text him and say, this is what I've got. What do you think? I think in a lot of places you don't necessarily get that. A lot of people who are employed through the high school directly or the district, you may or may not have that. So a lot of times I think you feel like you're out on an island.
Yeah.
Whereas at least in the outreach setting, you've got coworkers, you've got people you work with that, you can at least, even you can text them, hey, this is what I'm seeing. What do you got? Like,
yep.
Um, I think that's, to me, I think that's, again, if done correctly, I think that the hospital-based outreach is probably the future of secondary schools. I think for collegiate sports, I think you're getting the same thing. A lot of people are moving to that kind of medical model, whether it be outreach from a hospital or you report to the physician.
Sure.
And again, I think it's good for athletic trainers. And I think some of these other settings is so variable. I think I'd be a fool to try to say that I could predict where we're going to be in 5 or 10 years.
Agreed.
Even at Shriners, that we're constantly evolving, and what can we do to be better? And I don't know who said it to me, but somebody said, if you're not getting better, you're getting worse. So I think there should be that constant state of change. But I think we've got the national organization is kind of doing a great job getting out there, advocating, working with the NFL, working with the APTA. I think we're getting in the right direction. But some of those things we're working on have been that was the way they were for forever. So, we're having to kind of chisel out of that mold a little bit, and kind of show everybody what we can do. So I think the future is bright. Obviously there's a lot of controversy around the Masters, but it is what it is, and we gotta roll with it. There is no more debate about it. It's happening. Right. So I think some of us get caught up sometimes in, should we do it? Should we not? It's like, well, too bad. It's already happening. So,
agreed.
So we can whine about it, or we can make it work. So
be okay to disagree, but still move forward.
Right. Exactly. I had students from the first couple of classes of the Masters at High Point University, and they're great. They're probably much better athletic trainers than I was, and definitely both smarter than I am. So, I think, and it's like anything in any profession, there's good and bad. So it's hard to pin the whole entry-level Masters on. If there's a couple of students coming through that aren't great, like how do you generalize that to the whole thing? But like I said, I think we're heading in the right direction, and it may be slow as much as that pains me to say. I want things done now, and I want it to be the way I want it to be. But we got to be in it for the long haul as a profession, and just keep trying to do better every day.
What advice would you give yourself if you could go back when you were a younger athletic trainer?
I think it's just good. I think one of the coolest things was go to NATA and talk to the Green Jackets. Some of the stories that they have are, you could spend your entire time there just listening to them talk. I mean, obviously, things have changed over the years, and we do some things differently, but there's some things we still do the same. Some of those things that are bread and butter, like, and even some of the wild stuff that they used to do. It's amazing to hear where we were, what they did to get us where we are and where we're going. And, I think a lot of people have that misconception about how the professional organization works, but, talking to those people too, what is Tori Lindley saying? What is Kathy Derringer? What is Kathy Flanagan going to say? Like, there's this like misconception that the NATA is responsible for our salaries, and that, that's not the job of our organization. I mean, certainly they can advocate for better pay, but
right.
People think that's their job, and ultimately that falls on us. Like we as a profession are taking these jobs. Nobody at home, nobody at the office in Oklahoma is going to fix that. Like it's right. All they can do is hope that we don't take those salaries, but we set our own value. And
yep.
I think as a young professional is knowing that, like, don't settle for that job that's garbage pay. Like, if you accept that job, that is, you're saying that's an acceptable value. So I think that's important to remember, is to be your own advocate, because a lot of times you are on an island and there is nobody else there to advocate for you. So you got to do it for yourself. And again, I was fortunate. I feel like I've hit the lottery a couple of times. I've had some great supervisors and worked with some awesome physicians, but and keeping that up now is like, I still talk to the physicians I worked with. You never know who's going to jump jobs and who's going to be in that position. So it goes back to working the network. Like we're such a small profession. We're probably not even anywhere near 6 degrees of separation. Usually it's 1 or 2. So
right.
I think for the younger athletic trainers, it's, working at work, keep up those contacts, but in a genuine way, not
Sure.
not. I think LinkedIn kind of presents this like false sense of having a network, and yeah, you're connected on LinkedIn, but can you call those people? Could you list them as a reference? One of the things I learned from Chuck Kimmel. I'm fortunate to kind of get to know him over a couple of years and being on an ATA committee as a student, and he sends everybody handwritten thank you notes, and that was one of those things that it just stuck with me. I think a lot of people remember that. It's so uncommon these days that you think for somebody who's been in the profession for that many years and has all this stuff to do, and he still sits down and takes time to send handwritten letters. That is probably a lost art and is going to stick out. So, if you go to that job interview, send a written thank you note. It may not get you the job that time around, but if that job comes back open, or oh hey, let's call that person. They sent us a thank you note. That's really impressive. So I think it's just be genuine in who you connect with and maintain that and work your network.
What was the most influential resource that you found in your career? I have a hunch on this one, what you're going to say, but we'll give it to you anyway.
I mean, the easy answer is Google, right? We've all got a phone. We can Google everything,
Fair.
Once you get out of the room for the BOC, you can always Google it.
There you go.
But no, I mean, in all seriousness, even with all this Corona stuff, I've been texting the couple of super people who were in my type of position with managing the outreach, like, hey, what are you guys doing with your athletic trainer, or athletic trainers that, one of them she runs a little bit smaller outreach program. So, and the other one runs a huge one with like 26 athletic trainers, so they're spreading them out over clinics. And, I think some of that is to know, like, okay, it's not just me. It's not me that, I'm not 100% sure what we're doing. Nobody knows what they're doing. So I'm in the right place. But, keeping those up and just, using those people as a resource. You never want to be, it's the cliche, but you never want to be the smartest guy in the room. That, there's always somebody else. If you don't have the answer, somebody else has it. So a lot of times it's not what you know, but it's knowing who to ask to get that answer. So
I like that. If you could change or eliminate one thing, could be a modality, a common practice, or a mindset, or whatever else you would like to set up in the field of athletic training, what would it be?
So my gut reaction is to say either Biofreeze or KT tape, but I think my first couple of years I was like, I'm not ordering KT tape, I'm not ordering Biofreeze. They don't do anything. And I apologize for anybody who's KT tape fans, but I think the last year I was at that school, I kind of had this realization. I'm like, okay, if this is going to help the kids feel better, why not? I think it's
a tool.
Why fight if the kid really doesn't need anything and they just want some Biofreeze and that's going to get them out the door and happy and feel good and go to practice.
Sure.
It gives me more time for the kids who really need my help or want, something a little bit more impactful,
Yep.
So I guess it's my real answer. I don't know that we should eliminate anything because there's always that, you got to have all those tools in the toolbox. You may have to knock some rust off every now and then, but you might need it for that one kid. So as much as I'd like to say we should get rid of one thing or another, I don't know that I would necessarily eliminate anything because we might need it someday.
I'll get that.
Maybe that's a little bit of the hoarder in me, but
Yeah, no. I think if we really came around to it, you could say we would eliminate the mindset that something is not useful because there's always a time and a place.
Right.
I love the stories I hear from people about they had lateral lower leg pain. All it took was a strip of white tape with no tension on it across it. That fixed everything. They go, I don't know. I don't care. It got them to where they needed to be.
Right. I had a kid with a shoulder instability, and he loved his KT tape, and I didn't have any with me that day. But our school colors were maroon and yellow, and I had a roll of maroon tape and just use that. Oh, this is great. It's like, hey, if that gets you to play today, then perfect.
Absolutely.
So it's I'm a little bit of especially traveling, I loved going on the road. I love packing everything up because it's that's your opportunity to shine.
Sure.
At home, you've got all your resources. It's okay, did you have the forethought to pack this or to pack that? And,
yep.
your coaches know, okay, if we need something, John's probably got it. Like, I loved going with wrestling because it was always, nobody else had anything that they needed, but, John's got everything. Other coaches in our conference knew, like, they probably didn't know my name, but they knew that guy had everything he needed.
Right. That's funny.
Even if I used it once a season, it's still in the bag. Like,
for sure.
So I guess I'm a little bit of an AT hoarder, but I guess that might have a use someday.
There you go. Yeah. Last question then. What does being an athletic trainer mean to you?
I think we just have such a unique ability to impact our patients. I think a lot of times we don't even realize it. But I think one of my most impactful was my first ACL as a certified. I watched his injury, got him off the field, got him to a surgeon, went in and watched his surgery, did his off-day rehab at school. But I think still one of my most standout moments, he came busting through the door with a room full of kids. He's jumping through and says, "Hey, read this note." He's like, "Read it out loud so everybody can hear it." And it was his final clearance note that he was cleared to go without restriction. He just his faith, his excitement was, that's it. That wipes away all the crappy days and the parents that are rude and the kids and the coaches that are rude sometimes that they don't get it. Those are the moments you work for. That it's, that makes up for all the late night studying, the couple of long nights at clinicals, all that stuff goes away when you have those moments. And although they're few and far between, it's, ultimately we just have that unique ability to connect with kids that he didn't bust through anybody else's door to read that note. He comes to tell you before he tells coach. It's that relationship you develop over such a long period of time. Nobody else is there from start to finish. Very occasionally you get the physician who's there, but they're not there every day for rehab. They're not, your PTs are not in the training room every day when they're having a bad day,
Right. And
how do you keep them through that? And, I think there's definitely kids that still, you're like, we were, did we help them enough or did we not? And sometimes there's that tough love involved. And I think for some of those kids, they remember that later, even if we don't think about it, that, we just have that unique ability to impact kids in a way that I think no other healthcare provider does. So I think that's it.
Well said. In closing, if people wanted to follow you or connect up with you, what are the best options? And we'll link all these up.
Yeah. So my email address is just jreidy10@gmail.com. Twitter is jreidy_ATC.
Yep.
And I don't know what the rest of them are, but
that works. That's perfect.
Get one of those, we can chat. But always happy to talk to people. And like I said, I think it comes to working network. That's the deal. Absolutely. So happy to chat with anybody and see what we can do.
Awesome. Well, we appreciate you taking the time.
Yeah, absolutely. Appreciate you having me
on physician extender and that role in the clinic. This has been good.
Yeah, awesome.
Thank you.
All right, man. We'll see you.